Good afternoon, everyone. Welcome to the Washington Medical Commission webinar series. Today, we are with Dr. Leslie Enzian, and she will be talking about optimizing care for people experiencing homelessness. Just a few things, housekeeping items before I turn the webinar over. Dr. Enzian, if you can change, there we go. If you have questions, please use the chat function at the top of your screen. We will answer your questions at the end of the presentation. If you have any tech issues, look for the help button at the top of the webinar portal. You can also click the more issue to figure out if your issue is a specific problem. And then just so everyone knows, the presentation will be available to everyone at the end. It will be available on our website. You will receive an email with the link and an evaluation. This is also how you'll collect CME. And please do follow us at Med Commission and use hashtag WMC to share what you've learned. Couple CME things before we get going. Dr. Enzian, if you could scroll down for me. I just want to make sure everyone knows that when you get that email with our evaluation on it, that is how you will, sorry.
It's not advancing. Oh, there we go.
So CME is a category 1 CME is available for everyone attending this webinar. If you are watching in a group setting, please make sure you register for the webinar and complete the evaluation as an individual to receive category 1 CME credit. And then just a little housekeeping. Everyone knows there's no funding or commercial disclosures that we need to have. Or we need to disclose to you. I'm sorry. And so with that, please fill out the evaluation once you're done. And you'll receive category 1 CME for today's webinar. Now, with all that out of the way, I'm going to turn it over. Thank you.
Thank you. I appreciate this opportunity to present today, and I thank you for your interest in the care for people experiencing homelessness. I work at Harborview Medical Center and have been a primary care provider for 28 years in a clinic that serves people experiencing homelessness and low-income downtown patients. And I'm also the medical director of a homeless medical respite program. I wanted to say that I feel grateful to the many patients who have shared their stories with me. I feel like it's a luxury to be able to work in a setting that allows me to, with rare exception, provide my patients with all indicated care, regardless of their ability to pay. And I'm appreciative to be living and working in a state that values and supports this. I'm going to just briefly go through some demographic information as a backdrop. So the reports of the number of people experiencing homelessness can vary widely. It depends on what definition of homelessness is being used and whether they're counting people in a single night as the point in time count does, or whether they're pulling from databases. This is national information from the point in time count, where one day a year teams go outside on that designated day and count everybody they can find on the streets, and the shelters tally up their census. And that misses a lot of people. It misses people in the hospital, in jail, people who are in a hotel for the night or couch surfing. So it's widely considered to be a significant underestimate, but it does determine funding allocations largely. So the US point in time count in 2023 this is a graph since 2007, and the blue line represents both those living sheltered and unsheltered. And in the last year, there was a steep 12% rise and to over 650,000 people. And this was the sharpest year-to-year rise that was ever recorded. And in Washington state, the count was over 28,000 on that point in time count. to further just review the scope of the challenge in Washington State, this data is from Snapshot Count, and that compiles data from three databases of unique people that were receiving homeless services during the month of January plus the month of July, and is more accurate in terms of count. And so there were almost 160,000 people experiencing homelessness. Of those, 6,000 were newly homeless in just the most recent month. Around 30% were chronically homeless, and there was a 21% rise in unsheltered homeless. And then on top of that, there were approximately 40,000 who were unstably housed, and those are people in transitional housing or couch surfing or receiving housing services. This graph shows statewide evictions by month since 2018, and the evictions, as you can see, were low during the pandemic eviction freeze, and then there was a drastic uprise from a backlog of evictions and then waning financial assistance for tenants who were behind on their rent. And then the highest numbers of homeless are concentrated in the West and in the Northeast. And the dark blue color has the highest number in New York and Vermont. And then we're in that next step down in terms of the next highest number of homeless people in our state. And if the numbers are looked at depending on what area you're looking at, of major cities, Seattle ranks third in the country behind New York and LA. If you look at largely urban areas, Spokane ranks, and Spokane County ranks third in the nation. And then looking at larger rural areas, Washington State ranks second. There is a disproportionate impact of homelessness on people of color. The orange bar shows the percent of people experiencing homelessness in the different categories compared to a Washington population in yellow. And in Washington, Blacks comprise 4.5% of the population, but nearly 17% of those living homeless are Black. There's also a marked discrepancy in Alaskan or in American Indian and Alaskan Native, and the data for whites is reversed, with fewer whites living homeless than is representative of in the general population. And around 41% of those living homeless are female. And when I started this work in the mid-1990s, the numbers ranged between 15 and 25%. So that has significantly increased. And the left half of this chart shows the 47% of those who are unsheltered. And of those unsheltered, about 20% live outside or sleeping outside, 20% are in vehicles, and around 6% are in abandoned buildings. This table summarizes the key self-reported reasons for homelessness, including job loss, family disruption, eviction or rent increases, and illness and hospitalization, in addition to substance use disorders and mental health issues. So in transitioning to discussing the health impacts of homelessness, I wanted you to consider this case as a backdrop to the information. So it's a 29-year-old male inpatient with new kidney failure. He has nephrotic syndrome, and on biopsy has amyloidosis that is related to opioid use disorder. He has been sleeping on the streets in a tent. He now requires dialysis 3 times a week for 4 hours at a time, and has a long and complicated medication list. And unfortunately, this is now a very common scenario. Similarly, we also have a large number of young patients with methamphetamine-induced severe heart failure. So for this patient with renal failure, what could go wrong? I think the easier question would be, what could go right? Because that list would be extremely short. This scenario is a setup for poor outcomes and high utilization. Is this patient going to get housing in the near term? No. Is he going to get a kidney transplant? No. And after this discharge from the hospital, he has a significant risk of near-term death. and we'll revisit this. So in terms of the impacts of homelessness on health, the meal programs that are available lack nutritious food. There is not availability of a diabetic diet or heart healthy diet. There's poor access to showers and laundry. There's a high rate of victimization, and those with mobility impairments or who are elderly are particularly vulnerable. Um, there are medical issues related to exposure to the elements, exposure to communicable diseases, and then a significant number of unintentional injuries. And one that stands out in particular, pedestrian people experiencing homelessness who are hit by cars. And then, of course, complications of substance use disorder and mental illness. And for those struggling with addiction, it is difficult to remain abstinent on the streets. Substances help numb patients from the harsh realities of their situation, and use often offers some degree of community. So in terms of the health impacts of that situation, people experiencing homelessness lack preventative and follow-up care. There's a 2 to 3 times increase mortality rate for those for cancer and heart disease. Many chronic illnesses are more prevalent in the population, and those illnesses are often delayed, have delayed diagnoses, are more advanced at the time of diagnosis, and are poorly controlled. There are higher rates of cardiovascular death in younger age groups, and the population as a whole is aging such that 50% are now greater than 50 years old, and that comes along with a higher burden of chronic disease. And then there is premature accelerated health decline such that people living homeless reach a geriatric health status in their 50s and 60s. So what are the barriers to care? The barriers to care really result from an intersection of physical, mental, and social burdens that lead ultimately to significant increase in morbidity and mortality. So one of the key barriers is that patients often have competing priorities that take precedence over attending to health issues. They prioritize getting a shelter bed for the night, standing in line to get what might be one meal for that day, getting a job for the day. There might be legal obligations, and then substance use disorder can be a full-time job in terms of needing to constantly secure access to the substance that someone is addicted to. There's a lack of storage, so theft of medications and phones, such that patients can't be contacted about appointments. Transportation is often problematic. Many patients don't have phones or spotty mail and limited internet. And there is a lack of places to recuperate or rehabilitate. So post-hospitalization, many patients are still not well enough yet to get by in a shelter setting or on the streets. And then there are significant barriers to getting into skilled nursing facilities, including people with substance use disorder who are methadone or maybe have exhibited some behavioral issues. Nursing homes in general can't discharge to shelters, and so they're leery, even if somebody doesn't have any of those previously mentioned issues, they're leery about taking a patient for whom they would not have a post rehab disposition. The staff in nursing homes also lack training on harm reduction and trauma-informed care, such that patients who do get into those facilities often don't fare very well and may be administratively discharged or leave on their own accord. So somebody who is hospitalized with a stroke or perhaps polytrauma from an accident and really requires rehabilitation for optimal recovery often cannot access those services. Patients often have a fear of bills. Low literacy is an issue, both reading in math in terms of figuring out dosages, and then just overall low health literacy. But additionally, there is low provider literacy in terms of what the realities of living homeless entail. And those providers who lack experience and insight into those realities create unrealistic treatment plans, such that patients often develop a mistrust in care, a belief that there's no point in presenting because they won't be provided with the recommendations that they can adhere to. And patients often have negative experiences, and many people experiencing homelessness report feeling unwelcome in healthcare settings and perceived discrimination. They often also feel shame about their hygiene or substance use, or about the fact that they're living homeless, and that can prevent them from presenting for care. And most don't have primary care providers. So the end result of all those barriers is fragmented and crisis-oriented care. Medication management is very challenging when living homeless. There's decreased adherence, and that could be related to cognitive deficits or mental health and substance use issues. And the reasons for poor adherence that patients cite are side effects that are difficult to manage on the streets, the cost of medications, the lack of a prescribing provider to provide refills. And in terms of side effects that are hard to manage on the streets, medications that cause dry mouth are problematic because water fountains are scarce. Those medications that cause frequent urination or loose stools are very problematic because toilets are hard to come by. And medications that cause sedation really increase patients' vulnerability, just as some examples. So back to the patient case of the patient with new renal failure. This patient had no access to a low potassium diet. He didn't take his diuretic because water was scarce, and he didn't have good access to a toilet. He at one point presented for dialysis and was found to have scabies, and is told he needed to get that treated before returning, but access to showers is limited. Because he has ongoing addiction, he's prioritizing securing substances over attending dialysis. Eventually, he gets started on methadone maintenance, but as you may be aware, dialysis chairs are hard to come by, and people are waiting very lengthy times in the hospital just waiting for a chair assignment. So nobody can be choosy about what time their dialysis starts. And so this patient has to dose methadone before attending a morning dialysis, and that is very difficult to achieve. So this patient often shows up late and gets partial runs, misses a lot of sessions, and ultimately is readmitted to the hospital with congestive heart failure and severe hyperkalemia, requiring urgent dialysis. His risk, again, of short-term death is very high. Homelessness is associated with a significantly increased risk of mortality, and studies have consistently shown a 3 to 4 times higher mortality rate than the general population. And if you look at those that are unsheltered, their mortality rate is 3 times higher than those that are sheltered, and 10 times higher than the general population. And cancer and heart disease is predominant among older individuals, and this mortality rate is still significantly higher even when controlling for substance use disorders. The average lifespan is 42 to 52 years old, and the tracking death statistics has largely thus far been limited to medical examiner data, which is incomplete, and we're in the process of improving that. But from the data we have, looking at a 10-year period of time in King County, the mean age of death was 49 years old compared to a Washington state life expectancy of 80 years old. And this is consistent with data from other areas. So over 10 years in looking at the causes, this graph shows the causes of death, and the dark blue represents accidental deaths, and that includes accidents and also includes drug overdoses and poisoning cases, which have been on the rise. And then a smaller number of natural deaths. And this image is a good compilation of the various factors that contribute to the high morbidity and mortality, including kind of the downstream causes of various diseases, and then the upstream causes of social determinants of health, like poverty and healthcare access, et cetera. And then the key factors that, this key social intervention and healthcare interventions that can lead to more positive outcomes, establishing a medical home, case management, harm reduction practices, for example. So along with all the health impacts for people living homeless, as one would expect, homelessness is associated with significantly increased utilization. And I've included more details in slides that I won't cover that are at the bottom of the slide set. But in summary, people experiencing homelessness have high ED and inpatient utilization once they're hospitalized. They have an increased length of stay. They're readmitted at a higher rate. And if you look at the subset of extreme utilization outliers, those are have way more extreme utilization compared to utilization outliers of those who are not living homeless. And this all leads to a very notable increase in healthcare costs. So common medical problems include a lot of dental disease, complications of substance use, a lot of skin and soft tissue issues, infections, frequent burns related to people who are cooking or heating often with propane stoves, or maybe inside tents that catch fire. And a lot of mechanical problems, friction ulcers, corns and calluses, just related to an ambulatory lifestyle, often poorly fitting shoes, a lot of venous stasis because people are on their feet a lot. They have prolonged walking, standing, and sitting. Those living in cars are often sleeping upright. There's a lot of venous stasis related, sometimes to injection drug use, sometimes just to sleeping upright and being on your feet a lot. And then we sometimes see pulmonary emboli from prolonged sitting in cars for people that are living in vehicles. And then a lot of exposure-related conditions, including immersion foot and frostbite, hypothermia. And we, despite the temperate climate in the King County area, see a tremendous amount of frostbite. This is an image of immersion foot with just very wet, macerated skin that often gets a super infection. This is a patient we care for in medical respite who had frostbite and declined amputation. Another view of that. Infectious diseases are more prevalent, cellulitis, respiratory tract infections, and then communicable diseases are also prevalent. There's an increase in HIV, and those that are living homeless generally have worse viral suppression. Viral hepatitis, particularly hepatitis C, is very prevalent. Every year we have at least one outbreak of norovirus and Shigella in the shelter systems. Sexually transmitted infections are prevalent. Tuberculosis is prevalent. There's a over 40% increased risk of contracting tuberculosis, and many that do contract it present with advanced disease. And then a lot of infestations, scabies, lice, bed bugs. Cognitive and functional impairment is very prevalent, especially for those over 50. And in one evaluation, about a quarter had a mini-mental status score less than 24. A third had difficulty with at least one ADL, and significant number of falls. And the prevalence of traumatic brain injury is very high, approximately 50%. And this is a risk factor for becoming homeless and a risk factor for remaining homeless. And often this is not readily recognized. It's hard to pick up in an inpatient setting where someone's medications are being managed by the nurse. They're getting all the bedside care, and the focus is really on acute care issues. The estimates vary in terms of prevalence of mental illness, but the prevalence is high and outcomes are worse. Those experiencing homelessness have higher adverse childhood experience scores. Those with severe mental health issues are 10 to 20 times increase in risk of becoming homeless. And just living homeless, even temporarily, is a toxic stressor with potentially sustained impacts on physical and mental health compared to those who have never experienced homelessness. So what are some potential ways to address all these significant problems? Successful models include programs that are low barrier for access. So primary medical homes that have walk-in capacity, one-stop health clinics where Pioneer Square Clinic where I worked had pharmacy on site, nutrition, podiatry, mental health, clothing, DME, social work services, and we provide a very integrated multidisciplinary team care. The other thing that is very helpful is to have embedded services in the shelter, so nurses and providers in shelter settings, and then outreach services teams that can care for people directly on the streets and into shelters that don't have providers on site. Collaborative care with the safety net is really critical, and this requires a lot of time reaching out to case managers, and this often falls on the provider. And so adequate time to see patients is really critical to being able to manage them appropriately. And in my clinic, for example, we had half-hour visits, and that was really necessary given the psychosocial complexity of the patients we were managing. In terms of substance use issues, a harm reduction philosophy is very successful. A trauma-informed approach is necessary. A lot of work needs to go into just rebuilding the trust in the healthcare system. And then a housing first approach is also important, but difficult to achieve. So it bears mentioning that housing is healthcare, and that healthcare and successful trauma-informed approach is necessary. A lot of work needs to go into just rebuilding the trust in the healthcare system. And then a housing first approach is also important, but difficult to achieve. So it bears mentioning that housing is healthcare, and that healthcare and housing are inextricably linked. And this was so apparent during the pandemic when we moved patients out of densely populated congregate shelters into hotel rooms. And it was absolutely astounding to see the impact on patients' well-being when they had privacy and safety in hotel rooms. So what are realistic treatment plans? So treatment plans really need to anticipate the possibility of poor follow-up. So it's also often helpful to engage case managers and peer navigators and ask them to escort patients to appointments, which many programs can accommodate. And then outreach teams can fill in the gaps for patients that don't show up. Considering multi-day dressings for patients you think may not follow up. For patients who have diabetes, optimal blood sugar control may not be safe and appropriate. So you might need to shoot for loose blood glucose control really to avoid the dangerous lows, and provide nutrition education that is grounded in the reality of what food is available. I often advise inpatient teams to consider having patients on regular diets when they're in the hospital, because otherwise the medications are being titrated to an unrealistic dietary intake that then leads to problems post-discharge. Insulin pens, when possible, are helpful. Reading glasses, that should be assessed whether that's needed for them to read the pens or the syringes. And then because skipped meals are very likely to happen, just to make sure that glucose gel or tabs are provided for those that are on insulin. In terms of addressing medication adherence, there just needs to be very intentional strategizing to optimize that. So simplifying medications as much as possible, once daily, if at all possible. For those who have phones, setting phone alarms, remind them of dosing, having patients get training on Mediset fills, or some patients might need to come into the clinic every 2 weeks to get medication sets filled, or get blister packs if they have an address that those could be mailed to. And then, of course, consider the side effects of the medications being prescribed, and consider avoiding medications that require monitoring. So if you need to recheck labs a couple of weeks after starting a medication, if you don't know the patient and you're not sure about their follow-up, that it might be best to avoid that medication. And then it's helpful to start independent med management in the hospital prior to discharge, just so the patient can demonstrate their ability to do that and get support or education around that. And then also to just be aware of misused medications. Clonidine is sold on the streets to help with opioid withdrawal. Gabapentin is also sold, and Phenergan potentiates opioid effects and is sold right outside of methadone clinics. So when patients come in with hypertension saying they're on a single agent of clonidine, given that's a relatively weak antihypertensive, there may be a secondary reason that they're asking for that. Additional tips for care: to ask specifics about sleeping location. Consider, because somebody, just knowing that somebody's living homeless is not informative. Are they in a tent? Are they doubled up with someone they can only stay with for 2 days? Or are they in a shelter? Because the management really should be tailored to that situation. For people who are 50 and older, consider assessing their functional and cognitive capacity. Definitely ask about literacy and tailored teaching and the plans to that. Ask about traumatic brain injury. Look at the feet and the teeth, and patients are often reluctant to take their shoes and socks off because they haven't changed their socks in a couple of weeks. So it's helpful just to use very normalizing language. I look at feet all day, for example. And then in addition to trial runs on medication management in-house, also removing urinals. So patients actually have to get up and get to the bathroom as they would in a shelter, or can be helpful to get insight into some functional deficit that might be there, or incontinence issues. And then it's important to address non-acute issues with episodic care, including screening and vaccination, because patients often will not ever get regular care to attend to those things. A trauma-informed care approach is really key to establishing a therapeutic relationship, and has been shown to improve patient engagement. And trauma-informed care recognizes the prevalence of adverse childhood experiences and trauma among all people, and assumes that an individual is more likely than not to have a trauma history. And it recognizes that many behaviors and symptoms are the result of experiencing and coping with trauma. So not personalizing patients' behaviors and minimizing reactivity. And trauma-informed care really shifts the question away from what's wrong with you to what has happened to you that might cause you to behave in this manner. This approach is grounded in respect and kindness, really using a client-centered approach where the patient feels that they're the key decision maker, using a strength-focused perspective to promote their resilience, and then also being aware of vicarious trauma to healthcare workers, and kind of proactively thinking about burnout prevention, supporting coworkers and maintaining perspective when plans fail, and prioritizing self-care. So I want to switch to talking about substance use and harm reduction. So this is fentanyl or blues that people, by and large, were smoking, and it was interesting that we were appreciative and that there was a significant decrease in endocarditis, septic joints, epidural abscesses, when people shifted to fentanyl use from smoking, although of course there were other issues with overdose, but those problems significantly dropped. But there has been a recent trend in returning to injection drug use that is very experientially evident and now is being reflected in the data. And so all those problems are resurfacing, and I imagine people are getting more tolerant to the fentanyl and switching to injection. So the relationship between substance use disorders and homelessness is bidirectional. So substance use disorders can precipitate homelessness, and then the rigors of street life might cause or perpetuate substance use disorder. And many patients also use substances to self-medicate for psychiatric issues. And a harm reduction approach is usually the best to take. And what is that? So harm reduction includes programs, policies, and practice that aim to reduce the adverse consequences of substance use without necessarily reducing the drug consumption. And it's grounded in a social justice movement that is based in the belief and respect for the rights of people who use drugs, and utilizes non-judgmental approaches to enhance patients' skills and knowledge to help them lead safer and healthier lives. So it's a very pragmatic approach that acknowledges that substance use is a part of our world. And it is sometimes incorrectly perceived as being opposed to abstinence-based approaches when it really is not. There is a need for both, and they're really complementary approaches, not in any way mutually exclusive. Harm reduction acknowledges that substance use disorders are very prevalent in the homeless population. Over 50% are actively using substances. Most 90% don't receive treatment, and that is because the resources are inadequate and many don't perceive a need for the treatment. And then it acknowledges that addiction is a chronic and relapsing condition, and abstinence, if achieved, is often temporary. So it works to minimize the harmful effects rather than ignoring or condemning the behavior. And it's clear that the abstinence approach has a limited efficacy and appeal, though it works for some people. People living chronically homeless with alcohol use disorder had a mean lifetime abstinence attempt of 16. 95% of those with lived experience prefer non-abstinence-based goals. Susan Collins at the University of Washington is a powerhouse in harm reduction research and has demonstrated that, and some of her research involved the clinic where I worked, that treatment engagement decreased as program demands, especially abstinence expectations, increased, and that many patients prefer moderation goals even after successfully completing abstinence-based treatment. So in harm reduction, any measure of lowered harm is considered a success. And this approach really doesn't minimize the real and tragic harms and dangers of substance use, but just acknowledges that some ways of using are safer than others, and that functional improvements can be achieved without abstinence. Focuses on optimizing quality of life. And there are many levels in which harm reduction can be integrated. There can be government levels in terms of decriminalization of substances, community level interventions like taxi rides in bar areas, and then individual levels of intervention. So in terms of overdose prevention, of course, Narcan distribution is key, and Narcan distribution is indicated for people who only use stimulants also because much of the stimulant supply is contaminated with fentanyl. Many shelter programs, some clinics have reverse motion detectors in the rooms or bathrooms such that alarm when patients stop moving. It's important to have very explicit conversations in discussing safer use practices, asking patients if they inject or smoke, would they consider smoking rather than injecting? Do they ever inject in their neck or groin, and discuss the associated risks, asking about reuse of needles and cottons, and asking them about whether they use alone, which is a high-risk practice. The King County overdose data dashboard is really impressive and updated in a very timely fashion. But if you look at this graph of overdose deaths since 2014, it's significantly increasing. The purple section that is also expanding is a combination of opioid and stimulant-related overdoses. It's not yet clear exactly what's going on. Would those patients have overdosed even in the absence of stimulant? But there is a thought that that there is a synergistic impact with the stimulants causing vasoconstriction and decreased perfusion, and then decreased respiratory drive with opioids, such that ultimately oxygen delivery, blood delivery to the vital organs is impaired. But there also is a progressive increase in the stimulant-only overdose. And this is something that in the homeless sector where we have not sorted out in terms of prevention and best practices for monitoring. I want to point out two great programs for patients to use. There's a Never Use Alone program where patients call this 1-800 number. Somebody stays on the line with them while they're using. If they stop interacting, then emergency services are activated. And then the Canary app is a similar program where if you stop interacting with the app, emergency services are called in. I want to talk about stigma and substance use disorder. And stigma can arise from the fact that while under the influence or in withdrawal, people with addiction often engage in socially objectionable conduct, and that can be perceived as deliberate. Substance use, even still in the medical world, is often perceived as a personal choice and moral failing rather than the medical disease that it has been shown to be. The impacts of stigma are compounded by internalized stigma and shame, and then structural stigma with criminalization adds to this burden. And ultimately, all of this leads to bias and marginalization, more risky practices, and care avoidance, and worse outcomes. One evaluation found that people who injected drug, a third of them did not seek care because of fear of mistreatment. And there was an interesting evaluation that assessed over 500 clinicians attending a mental health conference, and they presented vignettes. And in some of the vignettes, people were referred to as those having substance use disorder, and others they referred to as substance abusers. And the vignettes and where somebody was referred to as a substance abuser, that condition was associated with the notion that the character was personally culpable, a social threat, and that punitive measures should be taken. And those labeled as having a substance use disorder were perceived more as being victims and deserving of treatment. So the stigma impacts care and outcomes. And stigma reinforces an underinvestment in treatment resources that leads to inadequate access to treatment programs. The words we choose can perpetuate this bias and stigma, and unfortunately, stigmatizing language has infiltrated standard medical speak, and this language influences how we view and care for patients. And if we can individually model alternative language, then collectively we can contribute to a shift in our healthcare culture. And this is necessary and important work. And even though I've been in this business for decades, these stigmatizing terms still crop up on my tongue because they're so ingrained. But in general, we should avoid defining and labeling patients by their diagnoses or behaviors. And so instead of referring to somebody as a homeless female, they're a female experiencing homeless, they're a person first. We refer to dirty urines, and somebody's clean and sober as if they would be dirty if they were using. We often, for people who are living homeless, use terms such as a patient refused this treatment and somebody in a different social echelon more often would be referred to as having declined treatment. So instead of saying a patient refuses this, just saying a patient declines or they don't consistently take their meds. Somebody is a person with diabetes rather than a diabetic. We should avoid painting ourselves as saviors and the patients as victims and vulnerable. Although there are vulnerabilities, they also exhibit tremendous resilience. So somebody, instead of suffering from mental illness, somebody is living with that. And another one I just want to point out is that wheelchair bound. Rather preferable language would be somebody that mobilizes with a wheelchair. So other than words, how else can we tackle stigma? So emphasizing solutions can be helpful. Treatment options, overdose prevention, sharing sympathetic narratives that humanize patients, emphasizing the societal rather than individual causes can be helpful, and including those with lived experience in planning and services. Sorry, this just stopped advancing. There we go. Lastly, I want to just talk about medical respite programs. This is a blossoming service, and now our state is offering reimbursement for these services. So there are many more being planned, and it's really an essential part of the safety net. Sorry, I don't know what is going on with this advancing situation. This is our program in Seattle, the Edward Thomas House. We have three clinic rooms, and patients have hospital beds. We have 3 to a room with a shared bathroom. And we focus on providing short-term care for acute illnesses and injuries, but use the time to engage patients as a window of opportunity to engage them in services that will have long-term impacts. And out of all the many roles I've had at Harborview over the decades, this has been the most rewarding in that it is a very high impact program. And for years, respite patients became my primary care patients. And I just thought over and over again that a respite stay could be the pivotal experience that would lead to long-term social and health stabilization. Sorry, not advancing. So in respite, we care for a lot of wounds. We have patients there who are receiving cancer treatment. We have patients there for hospice and palliative care. We also would consider taking somebody, for example, who has a concerning lung mass, who's very disenfranchised and needs support around an expedited workup and treatment planning. And so just to wrap up with our patient case, this 29-year-old male with new renal failure, what are viable interventions? So a patient like this, hopefully would get admitted to medical respite to support successful transition onto dialysis. And the program would support independence in medication management, advocate for simplifying the regimen when appropriate, stabilize patients on medications for opioid use disorder if they choose that route, advocate for methadone carries or delivery because just keeping up with the dialysis schedule in itself is challenging. Connecting patients to outreach case managers that can follow them after respite on the streets or in the shelters. We connect them with our homeless palliative care team that also does outreach. Facilitating engagement with a primary care provider. We try to do care coordination with the dialysis center social workers so they're looking out for the patient after respite, securing a telephone for appointments, and then we try to keep them until we can transition them to a shelter with embedded medical support. So I will leave it at that. Thanks so much for your attention and be happy to take questions.
Thank you so much for presenting this super valuable information. It's so wonderful to have you and have someone with your expertise with us today. So I hope everyone will give Dr. Enzian a virtual round of applause. We really appreciate it. Just as a reminder, this webinar is accredited for Category 1 CME. You'll receive an evaluation after the conclusion of the presentation. Please fill that out, and you will receive your credit via email. Please feel free to use the chat function if you have a question. You can also raise your hand and I can unmute you. But while we have a couple minutes for people to kind of gather their thoughts, I have a question about the don't use alone and canary functions. Do you see how much recidivism do you see from these apps, and do you think they're contributing to overall health and getting care, initial care?
Um, well, I think they're really an emergent intervention. So I think I don't know what the data shows for those interventions, but I would say our expectation would be that it's decreasing overdose deaths and getting timely intervention for people that are overdosing.
And Mark has asked the question, how do most of your patients who are homeless get to your clinic?
Um, well, the clinic is located right at a hub near shelters, so many of them can walk there. They take buses. We provide bus passes. In downtown Seattle, we're lucky to have this transport van that does a circuit to First Hill hospitals and then down to the downtown area, so that's another option.
And do you have a mobile unit to treat patients?
We do. We do. The county does have a number of mobile units, and we also have some mobile methadone clinics, which are wonderful. But we have a street outreach team that will go into encampments and find people on the streets, and we have a lot of embedded services in shelters.
Do you think that street unit, that engagement team, how important are they in building that trust with healthcare providers in encampments?
I think very important. I think those who are choosing to sleep outside clearly are more disenfranchised, less likely to come in, and what they generally try to do is just establish rapport engagement and then transition patients, support them in transitioning to a long-term medical home. But I think it's a necessary service.
Wonderful. Well, I don't have any more questions in the chat, and I don't see any hand raised. So again, I hope everyone will help me thank Dr. Enzian for her valuable information today. I really appreciate it, and we're so happy to have you. Thanks, everyone, and I hope you have a good day.
Thank you all. Take care. Feel free to reach out with questions.
I'll post Dr. Enzian's information in case you have any follow-up questions. So please feel free to reach out to either one of us.
Okay.
Thank you.
Thanks so much, Jimmy, for your support and facilitating all this. Appreciate it.
Oh, we're so glad you could join us. It's so important, especially in Seattle, like you said, with the demographics. It's
Yeah.
a problem we need as healthcare providers need to pay more attention to and kind of reduce that stigma. So I'm very happy you could join us. Thank you.
For sure. All right. Take care.
Bye.
Bye.